Just thought I'd let you know who the heck I am first. Like, why is this guy even important to talk to us and what the heck's going on? So who is this Volansky goofball that's coming in talking to us on Zoom? I'm in Ohio. I was hired here as the program director to start a physical therapy program after James and a couple of other folks on campus decided that physical therapy was a good route for Augustana to go. But I live in Ohio. I mean, that's a 14 and a half hour drive away. So this in and of itself, being able to be here in Ohio and still be able to start a program and do things here. I mean, I live in Avon Lake. I'm west of downtown Cleveland. So this is like a pretty innovative thing. And whether you realize it or not, Augie is extremely innovative in being able to offer this kind of service or this kind of program. Our physical therapy students will take all of their classes online. They will meet every 8 weeks in the Twin Cities area, and they will do their lab practicals and lab testing during either 5 or 12-day sessions. So think about just having class all the time for 6 weeks and then flying into a central spot or driving into a central spot and then having nothing but 1 or 2 weeks of nothing but hands-on. It's actually shown to work pretty well. There are 7 other schools in the United States that are doing this. The therapists are able to graduate with a 95% graduation rate. So this does work. Who am I and why am I qualified to be here? All right, well, we'll start with the cheesy stuff. I married my prom date 30 years ago, so I've been married for 30 years. She's also a physical therapist. She's also a twin, which if anybody out there is an identical twin, you know that twins have their own language and world that they live in, that none of the rest of us will ever figure out what happens. I come from a family of 4. I'm the oldest. So if that makes you kind of figure out how oldest children work. I was experimented on and got grounded for an entire summer because I brought home 2 C's. My brother they were jumping up and down when my little brother got a C rather than a D. So times change. I like to cook, wine, like food. I have a couple of Porsches. I like to fly fish. Although right now, God tells me that I just need to practice my casting because I'm not catching any fish, but I'm really getting good at casting. I love computers and golf. And I love glasses. So I have like new glasses like every time you see me. So it's just like kind of like the fashion thing that happens. I went to the University of Toledo for my undergraduate bachelor's education for PT. I have a master's degree in business. I have a doctorate of science in orthopedic physical therapy, board certified in orthopedic physical therapy. So that's my skill set. I have a doctorate of physical therapy from Northeastern, and I have a PhD in biomedical informatics from Rutgers. I've been in private practice for 28 years prior to taking this position here at Augustana. I was in outpatient orthopedics, I was in industrial rehab, and I was also in home health. Owned all of those practices. I've bought and sold. I've created 7 companies, successfully sold 4 of them. My last company I sold to the University of Pittsburgh Medical Center. So one of the things that I hope that I can bring to the table here is to allow you to be able to see that documentation does make a difference. It makes a difference for a lot of different reasons. My teaching experience, University of Mount Union was the last place I was at teaching, but I also taught at a Medical College of Ohio, University of Findlay. Those are all in Ohio. I have a bunch of alphabet soup after my name. Honestly, it's like whenever I don't know how to do something, I go back and get another degree or get trained in something. And I think that's part of that whole lifelong learning thing that Augie is promoting. Whenever you don't know something and you realize you have a deficiency, go back and tighten that deficiency up. Be a learner your entire life. So I think that's what's important. So hopefully that qualifies me to be able to talk to you for 20 minutes. Today we're talking about documentation. So what and who cares about documentation, right? It's just a pain in the butt. I mean, if I'm seeing 20 patients in the clinic or 40 patients in the clinic, seeing the patients isn't the issue. It's sitting your butt down at the end of the day and writing all of those damn notes and getting your documentation in place. So why is it important and what do we do? Why do we do it? Well, we have a professional responsibility and a legal requirement to document. But in general, what we're looking to do is we're looking to make sure that we're documenting and giving appropriate care. We want to make sure that care is comprehensive. We want to make sure it's efficient. We want to make sure it's person centered. We want to make sure it's high quality. All of those things that pertain to your ability to be able to deliver evidence based care and do the right thing for the right patient at the right time. It is also huge for us to keep top of mind for documentation is to save our butts. If it's not written down, it doesn't and did not happen. So if you don't write it, it didn't happen. If you didn't say that you monitored that patient when you threw an ice pack on them, and you didn't say that it was only on for 15 minutes, and that person ends up with an ice with a burn, you're liable for that burn. And there's nothing to save you because you didn't write it down. The other thing is that your documentation is how you will be reimbursed. So reimbursement for athletic training is a completely different monster than it is for physical therapists. But in general, you need to document what you do so that you can prove and protect yourself, as well as the fact that you can communicate. What's really important is if you're covering a squad and you document what's going on with a particular athlete, and then all of a sudden, I don't know, you get quarantined for COVID and you're not there for 2 weeks, how does anybody know what it was that you were doing with that individual? They have no clue if it's not written down. So forget about billing, forget about covering your butt so you don't get sued. But let's just talk about just common sense. If anybody else wanted to pick up your notes and figure out what was going on with your treatment plan, if you didn't have an initial evaluation, if you didn't have a plan of care, if you didn't have goals, if you didn't have treatment notes, they wouldn't know where to pick things back up. So right now we're talking about documentation as it relates to just all the things that you've learned thus far about making sure that you have good communication as part of a healthcare team, and how you can communicate with your other professionals when you're taking care of athletes, no matter where they are and no matter what the age of that athlete, professional, non-professional, weekend warrior. But what's coming at us, and what's coming at us pretty quickly, and one of the things I want to spend just a little bit of time on, and I hope to open your eyes to this afternoon, is the fact that documentation now is going to be held in a central location. So up until now, your documentation was in a chart, in a file cabinet, in the back of the room someplace, in the back of the gym, in your office. We've come a little bit further than that with if you're using electronic medical records. So now your electronic documentation is held electronically. But if you're working, let's say, for Avera or for Sanford, that is sitting in a server at Avera or at Sanford. If you change jobs and you're now working in a private practice, you don't have access back into that system in order to get that information right now. What's coming at us and what's being developed right now are something called personal health clouds. What's important about this is, rather than the data staying with the electronic medical record at the facility that you worked at, the data that you put in for your patient, all of your notes, are going to go up into a cloud, and it will be set directly for that patient. So this is an example of what a personal health cloud is going to look like. So HIE in the middle is called Healthcare Information Systems, or Enterprise. But just say that's you. It's Kelly, it's Marissa, it's Jeremiah. You are HIE. You're right in the middle. So if I want to come in as a practitioner, as a physical therapist, and I want to see you, or you are an athletic trainer and you want to go in and get that information on your patient, right now, if you go in, you're not going to get anything. There's nothing there. In the future, which we're going to see, is we're going to see all of this other information is going to be sitting in one place. It will follow the person, and that will be huge. So your information from the hospitalizations, the labs, the pharmacies, other things that have gone on, images, your x-rays, anything else that you have is all going to end up being put in one spot. Your Fitbit data, the information from your iWatch, all of that data is going to go into one spot. This is going to be really important now, because if you are now documenting on what you're doing with your patient or your athlete and you put that into their personal health cloud, everybody else that has access to that patient now has access to your records. That could be used for good, that could be used for evil, that could be used for payment, that could be used for performance improvements or enhancements. But in general, this is going to be a good thing. And you need to realize that your documentation is now going to follow your athletes wherever they are in the system. And that's important to realize. Your ability to be seen as a professional in the healthcare system and to be part of the healthcare team is in large part going to depend on how well you're documenting and what kind of value do you show that you're bringing to the table as an athletic trainer and a treater of sports related injuries. If you're not documenting correctly, then when the physician goes in to take a look, when the PT goes in to take a look, when the payer source goes in to take a look, they may or may not realize what level of professional you actually are. So this is all up to you, and it will be under the microscope in the future for you as a professional. But the thing that's even more important to me, and the reason why I'm kind of jazzed about this stuff, is the future of healthcare is not only all the information in one place, but as soon as we get all that information in one place, we can now start to use machine learning and predictive analytics. And we can use machines to see relationships amongst the data that we as humans can't see. So that's part of that deep learning, machine learning, artificial intelligence. How do you take large data sets and make something of them? And if you look down here at the bottom, if you take your evidence and say, this is your documentation, then can we run an algorithm on that documentation, develop a model that then tells us what kind of things we might want to watch out for as a clinician while we're treating our patient. This is how your computer system of the future is going to help you as a clinician. My doctoral work was actually doing this. So I did my doctoral work and I looked at the ability to be able to predict deep venous thrombosis, so blood clots. But I was looking at free text. So as you were typing in your notes, not clicking on check boxes, but typing in your notes, were there words in the notes as you were typing that would be predictive of someone that would have a blood clot in their calf? So think about that. I took 30,000 patient records. I went through all of the free text typed in notes that a physical therapist did over 30,000 patient visits. And I came up with a prediction of what words correlated with a 95% probability with someone who ended up getting a blood clot in their leg. So why is that important? Well, not only are blood clots something that we all see, and you're going to see them as a professional as well with your athletes, and you need to pick up on them, but you may not realize that you need to go through the Wells rule. Do you remember the Wells rule? Do you remember looking at what it takes to be able to predict whether or not someone has, with some level of predictability, a clot in their leg? Right? So do they have swelling in their calf? Is one calf swollen more than the other? Is their whole leg swollen? Are they tender along the deep venous system? Do they have pitting edema in their leg? Was their leg recently immobilized? Can you see their superficial veins? Are the veins bulging in their leg? Were they on bed rest for more than 3 days, or did they have major surgery within the last 4 weeks? Do they have a history of cancer? See, what's interesting about this is that if you train a machine to look for certain words that are predictive of a blood clot, the machine could come up and say, Kelly, Marissa, Jeremiah, you know what? Based on what you just typed into the machine, I'm thinking that there's an 80% probability your patient has a blood clot. Would you like for me to pop up the Wells rule so that you can look at this screen right here and start to say, wow, maybe I should start thinking about the fact that maybe this patient has a blood clot? That's where documentation in the future is going to be really important. It's not only important that you document what's there, but you use the right words, the right terms, that you document completely so the machines can start to help you be a better clinician and see things that maybe you're not going to see as you're documenting. So documenting is not just all covering your butt. It's not all just there for legal purposes or for getting paid, but it's also to help make you a better clinician so that the machines can help you take a look at things. As it turns out, right now, the rules in the machines that are there are based on doctor's notes. Doctor's notes do not have the same words in them to fire the Wells rule that clinicians do. So physical therapists, when they documented deep venous thrombosis or blood clots, they talked about filters or ulcers or weakness or the lack of endurance or the fact that they were in a wheelchair. If you looked at these major words, they would not fire the right rule. So it's important that you know what the rules are. I'm not going to go too much further into it, but I do want to try to get you guys involved just a little bit here. So I know that you've talked a little bit about ankle sprains, inversion ankle sprains. That's like bread and butter, right? That's like boring. Inversion ankle sprain, yeah, great. But you got, that guy going up for a layup or girl going up for a layup or coming down off a spike and they land on top of somebody else's foot and they just roll that ankle, all right? Inversion ankle sprain. Take yourself off of mute. Tell me what kind of words, what kinds of things would you put in your documentation to document an inversion ankle sprain? What would you expect to see?
Like swelling and bruising.
Okay, so swelling, bruising.
Maybe like in different gait.
Okay, what about their gait, Kelly? What else would you put? How would you expect their gait would change?
Like they're favoring the other side, or it's like an antalgic gait.
Okay, an antalgic gait pattern. Weight shift,
Mm-hmm.
lack of weight bearing on the involved lower extremity. Marissa, Jeremiah, anybody else have any other ideas?
Level of pain.
Okay, so their pain level.
Mm-hmm.
You could talk about any deformity that you see.
Okay, are there any visible deformities? Catherine, Megan, Jensen, you guys got anything?
I just said the deformity thing. I'm Megan. Sorry.
Sorry. Gotcha. I gotta
I'm doing
watch
the screening desk right.
Awesome. Good for you. I'm sorry, I didn't see that open up down here. I get the little green box around whoever's talking. So let me look and see. Okay, there we go. I got it. So we have a numeric pain scale rating. We have weight bearing. We have gait changes. We have physical deformities. Anything else that you would expect to see if you were reviewing someone else's notes and they talked about an inversion ankle sprain? What else would be important that you'd want to know about that inversion ankle sprain? About the
where
athlete.
the pain's at, probably.
Where it's at.
Yeah, location of pain.
Good.
I mean, you kind of said this, but like the mechanism of like what happened.
Excellent. So just the whole description of the mechanism of injury. How did it happen?
And like previous history, ankle.
Previous history. Keep going down that road because you guys are going down the right road. What other pieces of information are really important when you're looking at an inversion ankle sprain? Do you think, let me give you a clue. I have a 6-year-old who has an inversion ankle sprain. I have a 65-year-old who has an inversion ankle sprain. Is there a difference of what you'd expect? Who's going to have a more serious inversion ankle sprain most likely? The 6-year-old or the 65-year-old?
65-year-old.
And why would that be, Marissa?
Because they're going to have a harder time healing than a younger individual.
Okay, so recovery is going to be an issue. What other reasons would a 65-year-old maybe have a more severe injury than a 6-year-old?
Their bones are going to be a little bit more brittle than a 6-year-old.
Absolutely. Now, conversely, what do you need to worry about in a 6-year-old? Well, maybe not so much a 6-year-old. What if I said 12-year-old?
Like growth plates.
Growth plates, yeah. So all of a sudden, you're not worried about that in a 65-year-old, right? So 65-year-olds, they just break. They don't really bounce. 6-year-old, 10-year-olds, they kind of bounce. They have more elasticity, but they have growth plate issues and things that you need to worry about as well also. So again, the age of the person plays a huge role into what's there. How about medications? What medications are they on? Let's take it one step further. Is there a genetic counseling program here at Augie? What role do you think genetics might play? What if you had a genetics report on this individual? What if you knew their collagen type? What if you knew their ability and their inflammatory response rate of what it was predicted to be based on their genetic profile? Do you start to see that there are a lot of data points, not only in what you have as a descriptor of what's going on with the person, but if you look at the entire person altogether? And do you see that if you have all of that stuff in a cloud and you can get all that, like I can get their pharmacy information, I can get, have they had this x-ray before? How many times have they rolled that ankle? Is this the first time or is this the 7th time? Is there a proprioceptive loss? Is there something else that's going on? So documentation makes a big deal and a big difference. And where I was going with this, and you guys did a great job with that, is I was going with the Ottawa ankle rule. Anybody remember the Ottawa ankle rule? Right. So the Ottawa ankle rule is taking a look at palpation and the probability of fracture and the need for an x-ray. So if they have pain at the posterior edge of the lateral malleolus or the distal edge of the medial malleolus, if they have pain at the base of the 5th metatarsal, if they have pain at the navicular, bone pain when you're palpating, that's all indicative of a clinically significant fracture, which is greater than 3 millimeters in displacement, which means that they need to have an x-ray. Look at all the other things that are here from the Ottawa ankle rule. So not only is the Ottawa ankle rule here and it's useful for ruling out fracture, really cruddy at ruling in the fracture, so it's sensitive, not specific. We're looking at other things here. We're looking at the ability of the patient to bear weight. Can they take 4 steps even if it's limping? Other things. Were they intoxicated? Are they cooperative? They have a history of diminished sensation in their lower extremities. Do they have other swelling issues that are going on? So those are things that maybe you're not going to know right away, but if it was documented by other people in the healthcare system on the healthcare team, and you had access to this information, maybe you won't see this. The machine will definitely see it in the background. Perhaps the documentation that you put in as the athletic trainer during your rehabilitation efforts may help another member of the healthcare team identify an early diagnosis or be able to look at something and catch it in a proactive manner rather than after something happens or the person has a fall or they have another issue. We're just talking ankle sprains because inversion ankle sprains are easy to talk about, but let's talk about cardiovascular events. Let's talk about dizziness. Let's talk about heat stroke, heat exhaustion, and all the risk factors that may go along with that. Let's talk about history of diabetes, sensation issues, medications that people are on. So your ability to document not only covers your butt, not only gets you paid, but it's really important for that individual athlete to have good documentation by everybody who sees them in order to be able to convey information and communicate not only by a person, but quite more dramatically and with more frequency by machines, looking for correlations of things that exist. So hopefully that gives you just a little bit different of an idea, or a little bit more of an idea of what you're doing when you want to be able to. Let me back up. documentation is important, and it's important not just for the normal reasons, but for a more developing way, in more developing ways. It's more important as we're going along. I have a lot of stuff down here. I don't have too much here that's not too much of things that you don't know already. I'm sure you all know how to write a SOAP note. I don't know that you're good at it, but I know you all know how to write one, and at least you've heard SOAP. And you have that there. You have guidelines. The American Physical Therapy Association has guidelines of what should be in a note. I only put this up here for you to be able to take a look at, because if you are going into a chart and you have a patient cloud and you can go in and look, what kind of information does a PT document that may be the same or might be different than you as an athletic trainer, and will that information help you? Good for you to be able to see what kind of things you can expect to see in a physical therapy note. So I put that in here as well also. And also gave you a link to the MedCalc, which is for the Ottawa ankle rule, for you to be able to take a look. All right, well, enough of the sage on the stage and me yapping and doing whatever. I tried to be a little bit interactive, and hopefully it wasn't completely boring. But do you see that documentation has some future kind of big changes that are coming along in it? Great. Questions, concerns? I'm going to stop sharing my screen. You can just look at my ugly mug. And do you like my ESPN background? I was bored during a faculty meeting because you were talking about SOFIA requirements, which have absolutely nothing to do with me. And that's so I put together my ESPN. I'm actually taking sponsors. I'm going to have them up in the background here pretty soon. So I'm going to be quiet. Is there anything that you want to know from me as a PT, or I don't know, where I get my glasses, or kind of hair product I use?
And I got one question to get us started a little bit. I mean, 3 of the 6 of us here are going to physical therapy already, so that's, you know, kind of nice. But can you come up with a legitimate reason why the documentation standards would be different between an athletic trainer and a physical therapist if they're providing the same care? With the only exception being obviously billing, but like you were talking about, you know, what's in a physical therapy note. Do you think there should be a difference between a physical therapy note and an athletic training note?
So I don't think that there's a difference in overall. If we looked at the major categories of what needs to be included, a SOAP note is a SOAP note is a SOAP note. However, the way we describe gait, maybe being more specific with what we're doing. I mean, obviously, I would expect with anybody with an inversion ankle sprain, I see Ottawa ankle rule, I should see negative medial malleolar distal tip pain, negative lateral malleolar distal tip pain. I ought to see the word navicular. I ought to see base of the fifth. You know, I ought to show that there needs to be that documentation in there. So I'm thinking, James, it's probably more along the lines of what is the level of detail that you get and what are the words that you use to describe the conditions versus is it going to be any different? I mean, so, and that was the big deal, I guess, what I was trying to say before. I mean, when a physician describes somebody with a blood clot in their leg, they use a certain set of terms because they treat it a certain way. You're going to see things like D-dimer and Lovenox, and so you're going to get drugs. You're going to get diagnostic terms from a physician, but a PT is not going to see that because we see it when it first happens. So we're going to see redness, swelling, pitting edema. We're going to look at those kind of things, but maybe you would see erythema. Maybe you would see, you know, whatever kind of, you know, maybe you're looking at lymphatic problems with the person, you know. So again, we're all talking the same language, but maybe using the different words. So that would be the only reason why I would see there would be any difference. The categories should all be it should be the same thing.
And I think I set that up nicely with you. We'll go through. I mean, there is a lot of truth to the fact that, you know, as athletic trainers, you know, that's the expectation across healthcare. We just don't do it sometimes. And that's really on us. And I mean, as Matt said, that's going to be a significant hindrance to the development of athletic training as a profession if we don't take the time to document the quality outcomes that we can have with our patients. You know, if we don't document the quality outcomes that we have, especially as more and more people get access to healthcare records, and it will just completely keep the profession back as a whole.
It's the truth, and it's human nature as you're going along, and the physicians look at you because they're used to a certain level of documentation. So everything is kind of trying to keep up and be on that same playing field. So rather than saying I have ankle pain, it would be really nice if you were a specialist to be able to see I have posterior talofibular ligament pain at the insertion, and and looking at something like that. So you're it's how you present yourself as a professional that matters. And for other professionals, especially professions that are more developed and have more reimbursement, because that's really honestly what we're talking about. We're not talking about specialty. We're talking about reimbursement. Physical therapy gets better reimbursement because they were part of an offshoot of nursing, and we do things in a reimbursement world. Athletics doesn't get that. But you are an athletic sports injury specialist. You just don't get that respect from the fact that you don't get major insurance companies that are actually insuring your clients as you're doing your work. You are a really important part of the healthcare team. I defer to ATCs all the time and would rather have an athletic trainer on my team for sports-related rehabilitation because you are more focused and more specialist than any PT that we train. So the only way a PT is going to come anywhere close to what you are trained to do is if they have a board certification in sports, and chances are they probably already have a degree in athletic training prior to getting their PT degree.
And I mean, I'll shut up and do any questions, but in case you're not convinced of that this is actually happening, this is a group that we've been asked to join. It's that concussion study you've heard me talking about a little bit, and this is the DoD funded military athlete study, and you can see all of the things that they're collecting, including accelerometer from a mouth guard, phone data, blood work, MRIs, all that sort of stuff. And then this perspective is going to take, artificial intelligence and analyze all of this from all of these different schools. So it really is, like here and coming. It's just, I think we're a little bit behind even most athletic trainers in our clinic.
Yeah, wearable sensor data is huge. It's huge. And especially if you're wearing padding, it's so easy to slap a sensor on a pad and be able to see geospatially where the person is, how much they're moving, what kind of acceleration and deacceleration forces are they being submitted to. I mean, there's all different kinds of things that are out there in all sports. Yeah. It does make a difference what it is. So,
and we can only
that's becoming the norm.
If we write it down too. So that's part of it.
Yeah.
I mean, not trying to beat a dead horse, but I know from research that this session isn't going to hold water against your clinical preceptors. You're going to document and do stuff like your clinical preceptors do. So I'm just trying to really beat it into you, at least for, this half hour, the importance of that sort of stuff. So I'll shut up. Any questions or anything? I mean, Matt's here, I'm sure, for anything. So if you have any questions on any of that sort of stuff, he's always been a great help to me and everyone else.
So there's athletic trainers are going to be a big part of Augie going forward. If you're not already a big part of Augie, PT programs are going to be developing, and we're going to open our arms up to the athletic trainers. If you want to be a PT, there are going to be lots of different ways that you can do that. So we're going to take care of our alum. And you guys right now are probably just on the tail end or very beginning of missing some of the opportunities, but we're going to reach back for you if that's something that you want to do. So I didn't say that because officially I can't market. So I never said that, but.
When is the program supposed to start?
June of 2023.
Okay.
So the summer of 2023. So go out, get your license, get your certification, and then if you decide that you want to come back to school, You can remind me that I never talked to you, and then we'll go from there. And I'll tell you what, it's not only just that, but one of the other big things, and let me just give you a couple of seconds and then move forward, is that payment used to be based on procedures that you do. So if I put an ice pack on, I got $5. If I did neuromuscular education or I did weight training, I did this much with, and I got, maybe $50 or $30. And so that's how you got reimbursed in the clinic. What almost everybody's going to is a prospective payment system that gives a lump sum to take care of an individual for a particular period of time. So why is that important? Well, if I can deliver the highest level of care with the least expensive person or professional, then I'm going to do that. So if an athletic trainer can prove their worth and you can do the job better than I can do it as a PT, you're not going to cost as much as a PT, so you'll get a hell of a lot more work because you're cheaper. Until you get really, really good, and then you won't be cheaper anymore. And then somebody else will come up behind you. And then there'll be another profession that will come up and do things with you. Does that make sense to you? So if it costs if it costs $150 for a physical therapist to see this patient that has a sports related injury, and it costs $70 for an athletic trainer to see that patient, why would I spend $150 if the athletic trainer can do it for $70? And then if you're the athletic trainer, you're trying to then show your value to be able to expand and say, not only can we see this, but we can also see these other things that are going on because we're showing that we're professionals and that we know what we're doing. And so that's how you become part of the healthcare team. That's how you add value. And that's why it's important that you document well and that you learn evidence-based practice and that you follow all of those things that your preceptors are going to tell you to do when you're out there in the clinic. Because this is a big deal. It's a really big deal. And that's how your profession moves forward.
It's also how you get healthcare, salaries and not athletic salaries.
Yeah, that's right. That's right. And I'll tell you,
conversations as well.
In concussion right now, concussion prevention is going all the way down into peewee sports now. They're talking, somebody slips and hits their head anywhere, no matter what their age is now, they're going into concussion protocols, which is not necessarily a bad thing. I think some of it's a little overkill, but I'd rather see that than not have it addressed at all. Because I know plenty of my friends that were back in the day that had concussions and they might have been borderline stupid to begin with, but they're really stupid now. They really have some issues, some neurological issues that are going on. So
someone has to have one question. It's a rule.
I did have one just from what I've seen at the field house with documentation with my preceptor compared to documentation with all the other physical therapists around us. They have more of like a software program. Is that something like as an athletic trainer, we can kind of see evolve a little bit more to where it's easier to input information? Because right now we're doing the very basic of documentation of just Word document what we did with the patient, how much weight and for how much time. But is there going to be like a more program development?
I would see that there would be because of that personal health cloud that I spoke of, Catherine, that information needs to be electronic. Otherwise it's useless. If it's on paper, it doesn't make a difference. You can never use that. And what I would also see is the fact that you have all these wearables and sensors and everything else. A lot of your athletic fields and more are more commonly set up with Wi-Fi and the ability for you to be able to document right on the field or right in the gym or wherever it is that you are. And it makes sense for you to just have a tablet to be able to do your documentation right there. So I think that is becoming more and more the norm.
Okay.
If you don't see the reason why you're not going to see it is because most of those services are expensive, but there are a lot of almost free, $15, $20 a year ability for you to be able to do documentation. If you work for a healthcare system, they're going to insist on it.
Yeah.
Is that electronic documentation, which slows you down until you learn how it works, but it is.
Okay.
But does that answer your question?
It does. And right now I'm kind of just writing on a piece of paper as we're going through the program with my preceptor, and then I kind of go back and document afterwards. But the PTs around us, they have all these different windows open as they're after
Right.
each patient, kind of typing in info and like down clicking and selecting whatever pops up. So
You know how good Siri and Alexa and these devices are getting with your voice?
mhm.
You know how you can, like, if you're in the car and you want to, just, dictate a text, you can just kind of say, Siri, and you can just kind of text it in or say it. And sometimes it's pretty accurate. Sometimes it's not.
Mhm.
That whole capacity of machines to listen to people, humans talking, will become to the point where you're not going to have to do that. They have it now for surgeons, because if your surgeon has their hands in you and they're doing their surgeon work,
Yeah.
they also want to be able to say that they are repairing the distal third of the proximal portion of the lateral aorta with a number 3 suture, blah, blah, blah. And the machine is listening, and it's putting voice to text, which is
Mhm.
automatically putting it into the surgical report
Okay.
using the same terminology. So I think you're going to start to see that start to trickle down.
Mhm.
To be able to use more voice than texting and having 9 million records open. Where you're going to see that, though, is you're not going to see that at Sanford and Avera, because it's way too expensive for them
Okay.
to put it in. You're going to see it at the smaller clinics that are more
Okay.
agile.
Okay.
Like the independent physical therapy clinic or the sports performance center that
Mhm.
is going to put that in place, because they're going to use Siri on top of some other program in order to be able to do that. But I think you're going to take away that manual having to write things in, and you're going to be able to use speech to text, and that's going to be
Mhm.
that's a big deal. That's already starting to happen.
Yeah. That'll be really helpful.
And this whole 5G thing, the 5G is the 5th generation of wireless internet over a cellular tower. And what's big deal about that is that it's now going to put you up to terabyte speeds. So you're going to have 1,000 megabytes up and down. So it'll
Mhm.
come down at you as fast as it'll go away from you.
Okay.
And once that happens, you can pretty much you can stream live video directly to a physician to be able to take a look at somebody. You know what I mean?
Mhm.
It's going to be huge. Movement analysis alone, and looking at being able to take video and slow it down in slow motion and look at mechanics. I mean,
Mhm.
that's just, we do that like all the time in PT. How do you analyze gait on a runner without being able to do slow motion?
Mhm.
It's almost impossible, let alone throwing mechanics or anything else that you need to be able to do. So there's a lot of technology that's coming along that's really going to help move us forward.
Yes. Okay. Thank you.
Well, listen, I respect all you guys being in quarantine. I am so the world sucks that happens. The good thing is that if you're in quarantine, fingers crossed that you don't have the cooties. And let's hope that right now, that as things are mutating, that right now people are getting infected, but they're not dying from it at the levels that they were when this thing first started. So I think the human condition itself is starting to generate some immunities to this darn disease. And you guys are young, so hopefully you're all young and healthy. And if you are in quarantine, fingers crossed that it doesn't turn into COVID. And if it does, it's not the end of the world. Very few people are passing away from COVID, especially people at your age. So have the flu, let it suck for a week or two, and then move back on. And then you can say you're a COVID survivor, right?
There you go. All right. Well, thanks a lot. Like I said, next week we will go into the business, talk about, the current system with, fee for service sort of stuff and all that fun stuff. So keep moving on, and I'll see you next week.
Thanks, guys.
Thank you.
Open invite. If you ever
Thank
need
you.
anything from PT, my email's in the system. Holler at me. Glad to help anytime. Okay.
Thank you.
Thank you.
Good luck to you. Be safe. Thank you, Dr. Day.
Thanks.